Thank you very much, Susan, and thank you to GS1 for inviting me. So, as Susan said, I'm the CCIO for Dedalus UK NI. I am a nurse by background, and I specialised in oncology and haematology before moving into the digital healthcare space around 10 years ago. I moved into digital to support whole genome sequencing in a time when it took about 2 weeks to sequence a genome, and consultants didn't have the availability to be able to prescribe against the medications that were reported back from the sequence. Nowadays, it takes less than a day to do a whole genome sequence, and there are untold numbers of precision medicines and targeted therapies available for doctors to prescribe to. I moved into digital and worked with Dedalus about 6 years ago. As for me, I really do feel that if we can get software right for healthcare clinicians throughout the hospital, we can really help drive efficiencies and improve patient care. And Dedalus was the right move for me. It is a company created by a clinician with all of our software solutions built by clinicians and for clinicians. I would say Dedalus is somewhat unique, as innovation and patient centricity are at the heart of our designs, and open standards are incorporated into all of our solutions. We work very closely with a number of other organizations, including GS1, and have a number of our clinicians who participate and even co-chair the GS1 demographic mission working groups. Not only does Dedalus incorporate open standards such as the GS1, GSRN, FHIR, HL7 and DIACOM into our EPRs and clinical solutions, we provide data platforms to share data between different software solutions. We provide the terminology server to NHS England, Canada, the Netherlands, and the HSE for medications. And we provide other apps, such as an app which allows the patients to have the full record in the palm of their hands, should the healthcare provider choose to release it. We also enable clinicians who work in the community to have access to the full medical record and work offline. And any work they do whilst they're working offline automatically uploads back to the EPR when the connectivity is re-established. None of that would be possible if you couldn't barcode scan and be absolutely convinced and trust that the information that you have in front of you is about the correct patient. So I'm now going to give you a brief history of the EPR. So when I say EPR, I mean the electronic patient record. This is used interchangeably with EHR or EMR, depending upon which country you're from. But in the UK, we use EPR. So if you go back to when I first qualified in the late 1990s, I do like to use ChatGPT to create my images. This is somewhat correct. And so you would have reams and reams of manila folders full of paper back in the 90s. You wouldn't have the doctors and the nurses working out of a room such as this, but you would have lots of notes in the doctors' clinic rooms while they were waiting for their patients to attend. You wouldn't have paper all over the floor. But the biggest mistake in this image would be the flat screen TVs. You didn't have flat screen TVs in the 90s. Now, some of the biggest risks associated with the dawn of the EPR, so when you were heavily on paper, might have had some digital systems, would be that you would firstly be unable to locate the patient's file. As a junior nurse back in the late 90s, I would spend hours trying to find the patient's record. The patient would attend the ward, and the record wouldn't be there. I would have to go round to the outpatient departments, the ED, anywhere the patient might have been in the last 6 months to try and locate this folder. And then if I did locate the folder and brought it back to the ward, there was a risk that actually the doctor hadn't yet updated that record, because that would be why it wasn't back in the medical records department. There was lots of risks with misidentifying patients, with blood transfusion errors and medication errors. One of the worst instances I can think of was a junior doctor completing a mini-mental assessment on a patient who was having neurotoxic treatment for chemotherapy. He picked up the folder, went into the patient, did a full assessment, came back absolutely panicked. This patient has no idea what their name is, when their date of birth is. We need to stop treatment. We need to put a big sign up. And the nurses who knew the patient were very surprised because we hadn't noted that the patient was confused. Now, what had happened was that the room was numbered 7 and 8, not 7 and 8. And the doctor had picked up the wrong medication, or the wrong patient record, and gone into the patient's room, sat with them, and then when the patient had given their correct name, the doctor was actually wrong in terms of the fact that they had the wrong information in front of them. So this is the level of risk that you can have if you have the wrong data in front of you. So if we move to today, we now have integrated digital solutions, meaning that we're able to share the digital record between those handheld devices, the medication devices, and the central EPR. Now, the EPR is the central record for all of the digital data for the patient in the acute setting. We're able to share information from primary care back to secondary care. So that's not fully adopted yet, but you are able to do that. And that's because we have those open standards available, using that data between the systems. And as I said, it's not universally adopted. The GS1 GSRN unique patient identifier ensures accuracy in the patient information. So if you as a doctor are going to a patient, we now have the confidence that when we scan the patient barcode, obviously we communicate with the patient to confirm the name, we can be absolutely confident that the information that we get up on that patient is absolutely the correct patient and not somebody else, which is extremely important these days. We have instances when our consultants and our doctors are using the GS1 barcode in emergencies at patients unconscious. You scan the barcode, and immediately, whilst you have people working on the patient, you can have all of the medical history right there in front of you in the palm of your hand. We have handheld devices which enable you to have full EPR access. And we have the dawn of AI. So at Dedalus, we are starting to incorporate AI into our solutions. We support clinical decision support with AI, and we have some ambient listening in terms of the functionality. We're being very, very cautious because we believe, there's this huge juggernaut of AI coming at us, which is absolutely brilliant in terms of opportunities, but we do need to make sure that we adopt it with caution. So let me take a trip to the future. What would we want in terms of the future of the EPR? So our goal would be to have healthcare becoming more preventative and less reactive. That we have less attendances for patients in acute healthcare facilities, that we're able to treat patients at home, or even have them managing their own healthcare. So patients will have access to their information on the handheld devices. All of the wearable devices that patients wear will share back automatically to the EPR. So how would we get to this utopia, which, by the way, is a strategic goal for most of the countries in Europe? So the UK at the moment is driving to left-shift care to the community. I know that Germany is doing the same, as is Spain and France. So we would need open standards. We'd need a global adoption of the GS1 standards, not just for patient identification, but also, as our previous speakers have said, around medication management, blood transfusion management. You can track the source of the blood right through to the administration, so that safety of that tracking of the blood from start to finish. We have open EHRs, so we can share that information from system to system, and having cloud-based data so that you can share that huge amount of data. If we now incorporate and think about the fact that we want to use whole genome sequencing data there as well, we're able to share that data in a secure way up into the cloud and back down to the EPR. We will have AI, and as I said, with some modelling guidance as per the EU AI Act, and adherence to GDPR. So we want to make sure that whilst we're enabling that data to be available, that we're doing so in a really, really safe way, so the patient has confidence that any information about them is shared and secure. And we have large-scale quantum computing functionality to enable the information to be worked in a much, much faster way. So how does that look in terms of the future for global digital healthcare outside of the EPR? We would have better global digital healthcare by enabling global connectivity. Again, having those AI-powered EPRs. the amount of data we'd have on the patient if we incorporate and include the whole genome sequence means that we can move much more to preventative care. We can have digital twins for the patient, which means we have all of the information about the patient, including their whole genome sequence, enabling doctors and nurses to be able to trial medications on patients without actually administering medications on patients, and be able to assess what the potential outcomes would be. So that's a way of moving to the future. Also, very much across the world, we're looking at population health data. So what trends have we got in terms of A&E attendances? Are pandemics due? What resources do we need to put into different parts of the hospital to manage the trends that are coming for winter or when there's different diseases around the population? So in conclusion, because I think I've run over, the next 25 years of EPR-driven healthcare will require cutting-edge software, next-generation hardware, global regulations, and an AI-driven interoperability. Achieving this vision will demand international cooperation to create a secure and patient-centric healthcare ecosystem. And I think central to all of this, regardless of what data we have, if we don't have the correct patient identifier for each individual patient, the rest of the data is irrelevant. Everything we put into the record has to be accurate, starting with that individual patient. And I thank you very much for your time.
Please join us.